Okay, so like I said, you guys have done the first, you've accomplished everything new in distance ed now. So you've done the seminars and now you've done your first exam weekend and now you know the drill and it's busy, but you guys did very well. So on Moodle, under anatomy, you can see how far we've come, right? You guys remember all that, like way back, right? And now we're into the thoracic cage. Don't have too much left. Please note that our next, like after tonight, our next anatomy class is on Sunday, January 29th, because Janie and I traded classes, okay? So instead of the 31st, it's the 29th. And I'll put the link on Moodle as usual. And I'm just going to erase that. We're going to do scalenes when scalenes are part of lower cervical unit. So that's this unit on the screen right here. Okay, so also on Moodle, I just want to make sure those of you in study skills are entering your top 3 because it's working. Some people have done it, so I know it works now. Yay! And here's the whatchamacallit, summary of the exam. So I put it with the questions that were the hardest. So only a third of the class got this right. So that tells me this was a hard question. It has to do with multifidi. So when we draw a multifidi, we sort of draw it like this. Would you agree if I'm drawing one on the left? So there's only one origin on the transverse process, but there are many insertions. In fact, there can be 1 to 4 insertions on the SP. And it always goes below to above. And now you're all like, well, now that you say that, I get it, right? Hopefully. Does that make sense? I think a lot of you picked 1 to 4 TP below. And the origin, there's just one origin, just the TP below. This one was, do you know the foot? So the base of the first metatarsal, what does that articulate with? This one was an image one, so I can't see the image, but it was apparently adductor magnus was maybe difficult to find. Pectineus, people often get this mixed up, but pectineus is on the superior ramus of the pubis. Gemellus inferior is part of your pigogos, originating on the ischial tuberosity. And ligaments, sacrospinous. So from the sacrum to the spine of what? The ischium. I think this one, the origin of TFL, people were, because there was lots of options with iliac crest and ASIS and stuff, so you had to know your directions. So it's superior to the ASIS. As we go down the spine, the vertebral bodies get bigger, so therefore L4 would have a big vertebral body. This question is asking for a transversospinalis muscle, one that spans 4 to 6 segments. So multifidi spans 1 to 4, rotators span 1 to 2, and semispinalis spans 4 to 6. The biggest one, the longest one. This one you had to pick the most medial bone. Sartorius, origin insertion. Maybe you guys were looking for pes anserine, but you have to think, where is the pes anserine? It's anterior medial tibia, right? Same place. These two muscles have a common insertion, and they form a sling or a stirrup under the foot. We talked about how adductor magnus can both flex or extend the coxa. Origin of sartorius. What action is shared by glute max and the hamstrings, right? And then now we start getting where 2/3 got it right. So these questions are starting to become easier, which is good. So how'd you guys feel about the exam? Good. Not so bad, right? All right, so thoracic cage. Same old outline. And I know, I totally understand that the spinal muscle, usually what gives students difficulty is the hip or the spine. And I know that. So that's why we do the hip. That's why the hip is where it's at, because it's not the first topic you do, right? It's once you're into it a little bit more. And as for the spine, we do lumbar, and then we're going to do thoracic now, and we're going to cover some of the same muscles. So it's going to act like a review. And that's also why I gave a minor CBA for the lumbar, so that you could use it as a study tool. So same old outline as other units. So we're talking about our thoracic. This is going to look very similar to the lumbar. So we're going to bend forward or straighten back up. And we know that that's spine or trunk flexion and spine or trunk extension. Those motions occur on which plane and which axis? Yeah, the sagittal plane and the x-axis. Very good. Bending to the side is also known as side bending, or sometimes you'll see lateral flexion, but we prefer not to use that if possible. What plane and axis are we talking about now for side bending? Yeah, frontal and Z, very good. How about this rotation? So we have rotation to the same side or the opposite side, which can also be called ipsilateral or contralateral. And what plane, excuse me, plane and axis is used for rotation? Transverse plane and y-axis. Now, remember, we talk about the direction the front of the vertebra moves. How are you guys doing with this? So multifidi rotate to the opposite side. This is the right multifidi causing rotation to the left. Is this better than before, or is it still a sore spot? Is it still difficult? Starting to get it? Yeah, that's good. It's a tough one. I know that for sure. Okay, so now as we move up the spine, we had the lumbar first, and now we're doing thoracic. Well, when we get to the thoracic area, we have the thoracic vertebrae, but we also have ribs, and our ribs move, thank goodness, because they have to move when we breathe, right? So when we inhale, really the only muscle we need is a diaphragm. And some of your intercostals will contract too. And the diaphragm will pull down and push onto your stomach and make the volume inside your rib cage greater or bigger. The space inside there will get bigger. So the air pressure, because it's a bigger space, the air pressure goes down and it's less than the atmosphere, the air pressure of the atmosphere, and air will rush in. And then when we relax, so our diaphragm stops contracting, it recoils, what's called a passive recoil, and it moves back up into this dome shape. So it's a passive activity, making the thoracic cavity smaller, increasing air pressure so that it's greater than the atmospheric air pressure and air comes out. So in physiology, you guys talk about pressure gradients, right? We talk about concentration gradients. Same idea with pressure gradient. It's going to go from, things want to move from high to low, from high pressure to low pressure, from high concentration to low concentration. That's all breathing is. Now we're going to get a little fussy on how our ribs move. So when we breathe in and we look at the top of our rib cage, so our sternum, that's your breastbone, our sternum, and our upper ribs. When we take a deep breath in, the sternum and those ribs move anterior superior when we breathe in. Oh no, I did not want this to happen. There we go. That's called pump handle motion. Okay, so if this, imagine this pump is on the sternum, right? And it's going to move like that, just like this pump, just like lifting this pump. Superior, anterior. So for exhalation, it'll just move the exact, oh, I keep clicking on the silly picture. There we go. So when we exhale, it's going to move posterior, inferior. Okay, so that's the front, that's our sternum, and our top 5 ribs are going to move in a pump handle motion. Up, down, up, down. Okay? How are you guys doing with that? You guys are quiet tonight. Okay, seriously. There we go. One more time, had to click that thing. Okay, now we're going to look at the lateral part of the ribs and the lower ribs. So this is if you imagine a bucket on its, and you turn the handle to the side, okay? Because we're going to call it bucket handle. So when we talk about the lateral part of the ribs, so like this part of the ribs, and when that moves superior, that's called bucket handle motion. Like as if you would lift this bucket and then carry it, or lift the handle to carry the bucket, that's the motion we're talking about. And during exhalation, the exact opposite is going to happen. The lateral part of the ribs is going to move inferior. Finally, we have two ribs at the bottom. They're called floating ribs because they don't attach to anything in the front. And they're said to move with caliper motion. So when we breathe in, those ribs move lateral, posterior, and inferior. And then exhalation is the exact opposite. A caliper is tweezers. As a fancy way to say tweezers. Good question. Okay, so we're now in the thoracic region. So we did the lumbar, we did L1 to L5, we talked about the sacrum in previous units, and now we're in the thoracic region. Oops. Oh yeah, the coccyx too. Okay, so this is, again, should be similar from the lumbar, because still when we're in the thoracic region, we have intervertebral discs, mostly made of water, and it's that jelly donut thing, right? So the nucleus pulposus in the middle, and the annulus fibrosus on the outside. They absorb shock, they separate vertebrae, and in between the vertebral bodies, that's where the disc is, and that's then becomes a joint, an intervertebral joint. So the vertebral body above with the disc, and then the disc with the vertebral body below. Same thing in the thoracic region. And just like in lumbar, we have, in the thoracic region, we also have facet joints. So we have the inferior facet of the vertebra above, articulating with the superior facet of the vertebra below, and that forms your facet joint or your facet articulation. In the lumbar region, the facets were said to be vertical and deep. Now as we move up to the thoracic, they're becoming more of a cylinder shape. Then as you keep going in the cervical region, you'll see that they're more flat. This has to do, this helps determine the type of motion available at that level in the spine, because motion depends on the shape of the joint. And then as soon as you stack two vertebrae on top of each other, you get an opening called a neural foramen or an intervertebral foramen. And that's where your spinal nerves come out. We have the same ligaments as before. So the ligamentum flavum, which is non-continuous, so it has starts and stops to it, and it's on the vertebral arches. The facet capsular ligament is on or around the facets. Interspinous goes between the spinous processes. Supraspinous is on the tips of the spinous process. Intertransverse goes TP to TP. Posterior longitudinal is on the back of the vertebral body, and anterior longitudinal ligament is on the front of the vertebral body. So this is all from, you'll see this exact slide in the lumbar unit. Now though, because we're in the thoracic area, we have to talk about the ribs, the sternum, and the thoracic vertebrae. So we have 12 thoracic vertebrae, and we have 12 pairs of ribs, and we have the sternum in the front. So you'll notice some similarities, but some differences when we look at vertebrae, when we compare thoracic vertebra to lumbar vertebra. So for example, it's very similar, but we have more facets now. The transverse process is much longer and points inferior. Oh, sorry. The spinous process is much longer and points inferior. And also your transverse processes are longer and they articulate with the ribs. So we have B here is an extra facet. It's called a superior demifacet. C is an inferior demifacet. We also have, on this extended transverse process, we have a transverse facet. And I'm going to show you a picture, a cross section. You can see that there's a tubercle on the rib, and it articulates with the facet on the transverse process. And we'll see that the head of the rib articulates with two demifacets, usually. And that's why we have extra facets, is because we have more articulations. As for the ribs, you need to know the rib head. So it's the part that articulates with two demifacets on the vertebral bodies. Just past the head, you have a neck, a narrowing on the rib. You have a tubercle on the rib, and that's what articulates with the transverse process of the thoracic vertebrae. So here. And we have a rib angle. So where have we heard this word before, rib angle? Yes, with iliocostalis in the erector spinae. Very good. So the rib angle is, people often think it's right on the edge of your body, but no, it's right where the rib starts to go anterior. So if you follow it out from the spine, you'll see the rib goes a little bit posterior, and then all of a sudden it starts to turn anterior in an anterior direction. That's your rib angle. And that's where you'll find your iliocostalis. So it's on the edge of the erector spinae, because the iliocostalis is the lateral most erector spinae. Now moving to the front, we have our sternum. So we have the, it's called the breastplate sometimes, or your breastbone, but the real name is sternum. If you look at the sternum and you trace its outline, someone said it looked like a dagger or a sword. So they named the top of it the manubrium. Well, if we think of manu or manual, right, that means hand, so that's the handle. And in there we have a jugular notch and a place for the clavicle, each clavicle to articulate, called the sternoclavicular joint. Then we have the angle of Lewis or the sternal angle, depending on the textbook you read. And the body, which is the biggest part of the sternum. And at the very bottom, we have this pointy, the very tip of the sword, and it's your xiphoid process. And that's the thing everyone says, you know, don't break that off when you're doing CPR. Don't do CPR too low, right? So if we look on the front, okay, so now we're looking at the sternum and the ribs, and we're going to take a look at the joints. So we have a costochondral joint. Costo means rib. So it's between the rib and the cartilage. There's a joint. And then because the sternum is covered with cartilage, and that cartilage then goes out and meets up with the ribs and also covers some of the ribs. And then we have sternocostal, so where the rib comes into the sternum. So these joints are on the front of your body. So what we've done, or what people have done, is they've classified ribs based on how they attach to the sternum in the front. So we said we had 12 pairs of ribs in total. And the first 7, so ribs 1 to 7 on each side, are called true ribs because they articulate directly with the sternum. When we get to rib 8, you're going to see that rib 8, the cartilage from rib 8 hooks on to the cartilage of rib 7 and then goes to the sternum. Rib 9 will hook onto 8, which hooks onto 7, right, and so forth. So those ribs 8 to 12, are called false ribs because they do not directly articulate with the sternum. Within these false ribs, we have ribs 11 and 12, and they are floating ribs. They're floating because they don't connect to anything. They just end right there, ribs 11 and 12. There's obviously fascia, muscle, and whatnot, but there's no bony connection in the front. Okay, so the anterior classification is true-false. First 7 are true. 1, 2, 3, 4, 5, 6, 7. After that, 8 will hook onto 7, 9, and so forth. And then 11 and 12 are their own floating ribs. Okay with that? "11 and 12 are at the very bottom. You can only see 12 in this picture. 11 is hidden. Now we're going to look at the back, so where the ribs meet the vertebrae. So I want you to notice that this rib head here is articulating with 2 vertebrae and the disc in between them. And then the rib also, the rib tubercle, will articulate with the transverse process here and here. So whenever we have a ligament that sort of does this, it's called a radiate ligament. And you can see them here. And then we have another ligament called the costotransverse. So that's from the rib to the transverse process. Costo, rib, transverse. So these are on the posterior surface, or posterior aspect of the body. So now we're going to give another classification for the ribs based on how they articulate on the posterior side. So here we have an example. This is a very rudimentary drawing. Most ribs are typical, said to be typical. So a typical rib, a usual rib, when we're looking on the posterior articulations, are your ribs 3 to 10. What they all have in common is they all articulate with 2 vertebrae. So therefore, they articulate with demifacets, and they have demifacets. Okay? Ribs 1, 2, and 11 and 12, so the first 2, last 2, they articulate directly with the vertebral body. So there's no demifacet, there's just a costal facet. And 11 and 12. Now, rib 2, sometimes, depending on the textbook, may or may not be maybe in either category, but for us, I find it's easy to remember typical ribs, 3 to 10, atypical, first 2, last 2. So rib 1, 2, rib 11, 12. So I leave it like that. And I won't ever ask you to define which one is rib 2 specifically. Okay, you're going to pick the best answer. So the atypical ribs do not have demifacets, and instead they articulate with only 1 vertebra. So this is the posterior classification. Oof, that's a lot, hey? All right, so we talked about breathing in and out. And we did, oh, here we go again. I clicked the picture. Pump handle. So for your superior ribs, 1 to 5. And the sternum, that's said to be pump handle. Then when we get to the outside of the ribs, that's our bucket handle. And then the very bottom is your caliper motion. Do you guys remember what we said about facets? How they open and how they glide open and glide closed? What do they do when we flex our spine? They glide yes, open. And in extension, they glide the opposite, closed. Now, what about rotation and side bending? Do you remember how that works? Nope. So they close on the side that you're rotating to and open on the other. Same thing with side bending. If I side bend, they'll close. If I side bend left, they'll close on the left and open on the right. Yeah, side bend, they open on the opposite side. Good. This concept is very, very important next year. That's why we're touching on it this year. All right. Your diaphragm, very important muscle. So its origin, basically if you took your skeleton and you traced the inside of the thoracic cavity here, all the way around. If you ran your finger on the inside, all the way around, that's the origin. Xiphoid process, the lower 6 ribs, the bodies of the upper lumbar vertebrae, okay, all the way around. This muscle is unique because of its insertion. It inserts into itself. What? In the broad central tendon. And I'll show you a better picture. This diagram is kind of tough. And it sits like a dome in there. So let's take a look at this next one. Do you see this now? So some of these ribs have been removed. Do you see how it's like a dome inside there? And when it contracts, it will pull down. So the central tendon is this white spot. So if we look at it, now we're looking like bottom up, okay? So it's like you've laid your skeleton down and you're looking up through the thoracic cage. And this is where you would have run your finger all the way along, all around. And look at all these fibers of your diaphragm will come into the central tendon, this white stuff in the middle. It looks like a mushroom. Yes, it does look like a mushroom from this angle. So it's one of the hardest muscles to draw, as you can tell. Of course, there are openings in the diaphragm. Very important openings. What's this opening? It's for the vena cava. Oh, do we need to get blood between our top and bottom halves? Yes. This one, what's this opening? Oh, it's for the esophagus. Oh, good. So food can actually get to our stomach. That's good. There's another opening. Oh, for the aorta. Is that important? Yeah, you bet. Right? So there's definitely openings in it because otherwise we wouldn't be able to survive. So that's the diaphragm. You have to know the innervation of the diaphragm. Absolutely. Then we have internal and external intercostals. So the internal intercostals start, I'm going to use the correct pens here, start on the superior surface of the rib below and insert onto the inferior surface of the rib above it. And they travel in a superior medial direction, like that. And then, so they would be lined up all the way around. Okay, you know, if you've ever ordered ribs, like at Tony Roma's, these are the muscles that are in between the bones, right? You're welcome for never wanting to eat ribs again. No, just kidding. And then, so if this is the origin insertion, okay, and that, which way does, which way will this rib move? This rib is the insertion, right? So it's going to move down. So that's going to help us exhale, right? If we bring our ribs down, that's exhalation. So your internal intercostals do exhalation. Now, if we look at the external intercostals, so these ones are more superficial, right, than your internals. They're on the inferior surface of the rib above. And they insert onto the superior surface of the rib below, and they run in the opposite direction. So like this. And now, what are these going to do? Well, insertion moves to origin, so these are going to bring the ribs up for inhalation. Fiber direction. When I say direction, that's fiber direction. So the fiber direction runs inferior medial. There you go. Yeah. And same thing with the internal. That's fiber direction. Because when we talk about fiber direction, we're talking about from the origin to the insertion, which way do they run? So they cross each other like an X, exactly, because that also gives strength so that they don't all run in the same way. Ooh, good questions. You guys are doing good. External direction runs inferior medial. No problem. Yeah, and if you overlap them, you'll form an X. Good. Now we have serratus posterior, superior, and inferior. Okay, there's two parts to this muscle. So the origin of serratus posterior superior is spinous processes C7 to T3. And serratus posterior inferior is also on spinous processes T12 to L3. And then the insertions are similar. So the insertion for serratus posterior, superior, your top four ribs, ribs 1 to 4. Some books will say 2 to 5. And then serratus posterior inferior is your bottom 4. Superior will help with inhalation. Inferior does exhalation. Quadratus lumborum starts on your iliac crest and on that iliolumbar ligament, and it goes to rib 12 and the transverse processes of the lumbar vertebrae. So it will help side bend the spine. And if together they can help, if they work together bilaterally, they will extend the spine. Let's talk about its RMA. What's its reverse muscle action? Do you guys remember reverse muscle action? So reverse muscle action is when so normally, anytime we talk about a muscle, we talk about the insertion moving to the origin, right? Insertion moves, origin stays. Insertion moves, origin stays. When we talk about reverse muscle action, now the origin is going to move and the insertion is going to stay still. So now I'm going to bring the red towards the blue. So O to I, exactly. So that will elevate my innominate, or it's called hip hiker. Every muscle has a reverse muscle action, but some of them, like this one, the reverse muscle action is very important. For example, when we walk, do we drag our feet on the ground or does our foot clear the floor? In normal gait, our foot will clear the floor. That's because our QL hikes our hip every time we walk. So that we don't, because it would expend a lot of energy if we were dragging our feet everywhere. Unnecessary energy. So it's called the hip hiker muscle because its RMA, reverse muscle action, is to elevate the innominate. As for its effect on rib 12, it stabilizes rib 12. Okay, so how are you guys feeling about RMA? Because it's going to be an important concept next year. And some muscles this year, it's really important too. Yeah, you can control it for sure. It all depends on which is more stable. Yeah, the brain decides, and other muscles help, right? The only reason, for example, here, okay, so you guys, everyone knows. So why do we, because that's the normal way. Like that's usually what happens. So for example, I can, if I'm sitting down, I can flex and extend my knee, right? Okay, so now I'm going to extend my knee a bit, plant my foot on the ground because I'm in a wheelie chair, right? My chair has wheels on it. Now if I contract, I can pull my body towards my foot. That's just, I'm just using the principle of RMA. So all it is which bone is usually more stable? That's the origin. And which one is usually more movable? That's the insertion for a muscle. Now we can change that anytime, right? We can do dumbbell curls or we can do push-ups, right? So things like that. If rib 12 is stabilized, what happens to rib 11? Well, if rib 12 is stabilized, usually the rest of the ribs are stabilized. Like the whole core is stabilized. You guys, this is good. You guys are doing good. Now we're getting into like the real stuff, the real fun stuff. Same idea as I'm not sure, Liz. What? Oh, no, this would be different. Stabilizing? This is stabilizing through muscular contraction, not through ligaments necessarily.
Well, stabilizes the coccyx to the spine, and my thinking is that oh, now I forget the name of it.
The
This one
muscle?
that we're talking about, yes, this one
Yeah.
that we're talking about stabilizes rib 12 to the innominate.
It just, not to the innominate, it just doesn't allow rib 12 to move.
Oh, okay. Okay, got it.
Yeah,
Thank you.
no problem. Okay, so that was it for the muscles that act on the ribs. So there's not that many new muscles to do this unit. Now, of course, more muscles, you will find later on, more muscles can act on the ribs, but these are our primary ones for now, okay? So you guys have to know all about the ribs, the thoracic vertebrae, the muscles. And then because there's not that many new muscles to learn, it's a really good unit to also review the spinal muscles, right? These two, interspinalis, intertransversory, hopefully are pretty easy by now, right? Because their name tells you a whole bunch, right? Interspinalis, so between the SPs, and intertransversory between the TPs. And then we have always, always in the spine, the origin is below and the insertion is above. Always, always. You will find that everywhere. And here's our favorite grouping, transversospinalis muscles. Where are these muscles found in the back? Good, in the spinal gutter. Very good. They all originate on one transverse process of the vertebra below. And then rotators go 1 to 2, multifidi 1 to 4, semispinalis jump 5, 4 to 6, whatever, the biggest jump on the SPs, all on the SPs. So bilaterally, all of them do spine extension. Rotators are really good at rotating, right? Multifidi do rotation, but because they're longer, they can also do some side bending. And same thing with semispinalis. It's going to do some side bending. Side bending is always to the same side. All of these muscles, rotators, multifidi, semispinalis, rotate to the opposite side. How are you guys doing with this? These ones are okay? So it's the erector spinae that are jerks. Is that what it is? And then here they are in depth. Oh yeah, and our semispinalis had regions. Ugh, who cares? So, is it really the erectors that are tough, a little bit tough? Well, sometimes it can be tough. So really, like at the end of the day, this is the slide I want you to remember. Um, if you know this and you know the concept that the origin is always below the insertion, you should get 80% of the questions correct, and that's good. So spinalis is SP to SP, and it goes to the occiput. Longissimus is TP to TP, eventually to the mastoid. Iliocostalis is the funny, kind of the funny one, like a lot of bones at the bottom, sacrum, iliac crest, rib angles, and then more rib angles. And then finally, when you run out of rib angles, it'll go to the next most lateral thing, which is your cervical TPs. All the same actions. Extension when they work together, side bending when they work independently, when one side or the other works. And as for the regions, again, if you know the general, so spinalis, you automatically know that it's always SP to SP until you get to the top. And origin is below insertion. So spinalis thoracis inserts into the thoracic. So it's got to originate below that. Okay? And then pick the best answer out of the options. But I don't really care. But even still, so if it said T1 to T5, well, is that upper or lower thoracic? Yeah, upper. So this means the same thing as upper. So that's another concept you have to understand, right? Don't let those numbers throw you off. What are those numbers saying? Oh, it's the top of the thoracic, right? Or look at T8 or T7 to T12. That's, oh, good, that's the bottom or the lower thoracic, right? So now, if you're a person that loves numbers, then memorize the numbers. Maybe you're a number person, but the questions may ask by number, but just don't let it throw you. Just say, oh, well, those numbers are higher or lower, or where is it, right? And then longissimus, right, is TP, and then goes to the mastoid. And again, origin is below insertion. And you should be able to pick the correct answer. And then here's your iliocostalis. The difference with iliocostalis is you don't have a capitis region because it doesn't go to the head. So instead you have a lumborum region. That's all. Right? And this one does the nice zigzag pattern. They all have the same action. So it's one less thing to try remember. Now, these are just the muscles of the spine, right? The deep back. There are definitely more muscles on your back, right? Can anyone name one? Yeah, your lats, latissimus dorsi, and they're in this image here. Your traps, and then what muscles did we just learn in the ribs unit? Your serratus posterior. So there's an example here. We also have muscles on our scapula. We have rhomboids. Those are all coming up later. So any more questions about the spine muscles? Now's your chance because you're still going to be tested on them forever and ever and ever. Oh, good. I was hoping somebody would say that about the rotating the opposite side because I want to do it. I want to go over it. If insert goes, it doesn't make sense. Yeah, no problem. Okay. So here's a vertebra, and there's some stacked on top of each other here. Okay, so there's one lower down, and the origin is red, and the insertion is blue. So the insertion is the TP, the origin is the SP. I know what I'm going to do. Where's my mouse? Here it is. Maybe this will work, maybe not. Oh yeah, it kind of does. Okay, see how I have two vertebrae stacked? Oh yeah, watch this. There we go. Okay. So insertion moves toward origin, correct? So the I, or the TP, has to go this way. First of all, this muscle is on which side of the body? That's on the right side. Oh my goodness, you guys. Hold on. I drew this wrong. What is the origin of multifidi? First of all, what is the origin of multifidi? Go. Okay, good. The origin is a TP. Yeah, I was doing it wrong. I was doing different muscle and we haven't covered it yet and I shouldn't stop it. Okay. The insertion is the SP. Group. Okay. Okay, so we see how I got two vertebrae stacked on top of each other. The origin is the transverse process. The insertion is the spinous process. So insertion has to move to origin. This muscle is on the right side of the body. Yeah, right? You just need to see it like this. But let me finish my story. So I got to move the spinous process towards the origin, and it will go like that. Hence, now I will be facing which direction? The left. Ta-da! Yay! Now, we are going to be learning about a muscle later that goes SP to TP, and it rotates to the same side, right? Remember we had Oscar opposite and same side Sally or something like that? Sally, same side? Yeah. Very good. Okay, I'm going to leave this in here. This is a good example. Okay, good. Any other questions about the spine muscles? Well, we are almost done. I thought it was going to take us longer. That's okay. I'm not complaining. I'm sure you guys are not complaining after the busy weekend you guys had too. Okay, so let's finish up the PowerPoint maybe, and then we'll call her a night. So the phrenic nerve. Do you guys know about the phrenic nerve? Yes, you do. What does it innervate? Yay, the diaphragm. Good. See, 3, 4, 5 keeps my diaphragm alive, right? And then in this area of the spine, we have thoracic nerves, and they're intercostal nerves, so they follow the ribs, between the ribs. As for major arteries, well, the abdominal aorta is important, right? Of course, we've got a lot of arteries in here, right, supplying our organs, splenic, gastric, hepatic, renal for kidneys, right? Inferior phrenic, and intercostal arteries as well. You don't have to know every single one of these, just some of those main ones. And a lot of it's terminology, right? So like hepatic, oh, that's liver. You know, the liver would be there, right? I want to say phrenic means diaphragm, but I have no idea, and now we're going to have to look it up. So here are the veins, and I am going to look up phrenic. Phrenic. Phrenic nerve. Oh, phrenic means relating to the diaphragm. Yes, that's awesome. Well, I don't know why. I just took a shot in the dark. Sometimes I gotta be right, you know? So for veins, you got your renal, your hepatic, azygos, hemiazygos, intercostals, inferior and superior vena cavas. Did we talk about Fayette's laws yet? I don't think so either. And this is something that should really be done in person. So I will add it next time I see you guys in February. And I won't test you on it till then. We will go over Fayette's laws in person because I have a little diorama thing that I can do, a demo. Feel free to read them though, but I will show them to you and it'll make more sense. All right, back to when we were talking about the shape of the facets and the facet joints. Okay, so in the spine, the shape of the facet joints change, and therefore the type of motion available changes as well. Okay, so if we start at the bottom, the lumbar region, the facets were very deep and vertical, and this allows for flexion and extension with minimal side bending and rotation. Then we move up. The lower thoracic region is really good at rotation and minimal flexion, extension, and side bending. When you keep going up, you get to the upper thoracic. Now we get a lot of side bending happening, not a lot of rotation or flexion and extension. And then when we get up higher in the cervical region, now we're getting, the facets are more flat and we can do our move any which way, flexion, extension, side bending, rotation, yada, yada. And that's important because our head contains our sensory, lots of our sensory organs for information, right? So we have to be able to move our head quickly to assess for danger. The saber-toothed tiger is coming. Watch out, right? No, I don't know. But that's the whole deal, the whole reason why we talk about facet joint orientation. The shape of the facet joints is because that's what dictates the type of motion available in certain areas of the spine. Have you guys done lymphatics, or not lymphatics, but like lymph in physiology yet? Oh, you're starting on it. Okay, so you're going to learn about the cisterna chyli. You're going to learn a lot about how important the diaphragm is to moving lymph. Okay, so that's good. That's really good timing, almost like we planned that, Sheila and I. So this diagram here reminds me of a question on your practical exam that some of you had difficulty with, and that was something like this. Which curves of the spine are congenital and which are acquired, or something like that. So what do we think about that? Yeah, so when we think about a newborn baby, right? All of their curves are which way? Babies are like a half moon. Yes, and a half moon this way. So the sacrum and the thoracic. And then when they start to gain control of their head, the cervical curve will develop. Then when we start crawling and walking, you'll get your lumbar curve. So this is congenital, thoracic, sacral, because they're the kyphotic curves. Cervical and lumbar are your acquired or developed after. Make sense now? I think we touched on that, but briefly. There it is, congenital curve. Acquired or adaptive after. That makes sense now. Why didn't you say it like that now? Okay, good. So of course, if we have normal curves, we can also have abnormal curves, right? You can have too much lordotic curve, that's lordosis. Too much kyphotic curve is kyphosis. And you can have a medial lateral curve, which is scoliosis. And yes, that is it for the PowerPoint. Way to go, guys. Any questions? I got one more question for you guys.